Good morning. Welcome to the Marin Communications Forum. I'm Michelle Fideli from First 5 Marin Children and Families Commission, and the forum is a monthly public policy series that First 5 offers to the community. A free gathering, just informational, and we're very glad you could join us today to learn some general introductory information about autism. And we have a great set of speakers for you today, and very glad you could join us. We're going to begin with Jessica Hobson.
About 5 or 10 minutes left because I don't see the timing. Hi again. I'm Dr. Jessica Hobson. I'm a licensed clinical psychologist, and I'm also an instructor at Sonoma State University in the Department of Psychology, and I also do some teaching in early childhood education. I teach a course on autism, and I also work clinically, and I do a lot of diagnostic assessments up in Petaluma. So I was asked to come here today and sort of open up with a discussion about sort of what we look for in terms of signs and symptoms of autism spectrum disorder and what's involved in a clinical assessment. That's a lot to pack into half an hour, so we'll do a kind of condensed version, and please do feel free to catch up with me later or ask questions. So we know the syndrome of autism has actually been written about since the 1920s in Russian articles by a female psychiatrist, but more commonly known are Connor and Asperger's papers in the 1940s. And the original descriptions of autism spectrum disorder highlighted an unusual way of relating to people, which Connor felt was inborn, and an unusual way of relating to objects in the world. And although the diagnostic criteria for the syndrome have undergone numerous revisions over the decades, and especially a widening and a broadening of the criteria and who would count as having this disorder in the past few decades has significantly changed, nevertheless, those core features of the condition have remained today. So one of the things that we are looking at now is how early can we identify markers of children who later go on to be diagnosed with the condition. And I want to highlight, this is a recent paper, but there are numerous papers sort of highlighting this similar finding that although we wouldn't diagnose autism until sometimes a little bit before the age of 2, sometimes as early even as 20 months, in infancy, around the time of the 9-month revolution, which is where babies begin to share attention to objects and people, they start to alternate gaze. So for instance, around 6 months of age, a baby might play with a toy and interact with a person, but around the age of 7 to 9 months, they'll start to share attention between an object and a person, and we call that joint attention. Typically, developing babies don't really start to do that until around the age of 9 months, and recent research is showing that babies who are not alternating gaze as much between objects and people, even by around the age of 10 months, show an increased likelihood of later going on to receive a diagnosis. So that's the social interaction piece that we think is really important. Let's see. Which part? Yeah, so a reduced likelihood of shifting gaze back and forth between objects and people at 10 months. In this particular study, but a number of other studies have found this is called joint attention. I'm going to give you an example of what that looks like. So here's a little guy. He's participating in a test called the Early Social Communication Scales, which is one of many observational measures where you can look at joint attention. And you're going to see that the tester pops up a little clown, and he really enjoys it. But what I want you to watch is that he doesn't just look at it and keep enjoying it for himself. He shifts his attention to the tester, makes vocalizations and gestures, looks back to the clown and back to the tester. And in fact, his biggest smile comes at the moment he's sharing that experience with her. So let me show you what that looks like. So he looks at the clown, up to the tester, makes a gesture, back to the clown, makes some happy sounds, and looks at her and smiles. So that's what we mean by alternating gaze, and that seems to be one of the earliest markers of the condition. Some of you may be familiar with the MChat. So decades already ago in the 1990s, the earliest version of this parent questionnaire, which was administered to parents of toddlers, identified that those toddlers who were not showing joint attention and also not yet showing pretend play, those toddlers were highly likely to go on to receive a diagnosis of autism. So what we're seeing here is that, many, many decades, as the diagnostic picture sort of continues to develop and changes, we have a set of difficulties in what are thought to be two different areas. One is social communication and interaction. So that's like joint attention, sharing interests, reciprocity in communication of all kinds, including in conversation. We can say a little more about that later. And joint attention. These are thought to fall under the domains of social interaction and communication, but at the same time, we have difficulties with restricted and repetitive patterns of behavior, what Leo Kanner called the need for sameness. And under this category, we put behaviors such as being preoccupied with parts of objects, difficulty with transition or change in routine, stereotypical motor movements, rituals, fixated interest. And we call these two different domains, category A and category B. I'd like to argue that actually these domains may be connected if we look developmentally. So this is a video taken from the Autism Diagnostic Observation Schedule, or the ADOS, which is one of our assessment tools, and I'm going to say a little bit more about that tool. But I just want to show you this video clip. In this video that you're about to see, I'm training a group of psychiatrists, psychologists, speech and language therapists to use the ADOS. So I'm the trainer. The man about to sit down is a trainee. He's a psychiatrist learning to use the ADOS. And the adorable little blonde boy next to the bunny rabbit is my son Matthew, and he's 12 months of age. Matthew's not on the autism spectrum. You're going to see this stranger who Matthew's never met before sit opposite Matthew and try to direct Matthew's attention to a bunny rabbit that's actually off to the side and behind Matthew. It's also a toy that Matthew's never seen before. And what I want you to notice is how Matthew follows the man's gaze to locate the rabbit. And when the rabbit comes to the table, how Matthew and this stranger coordinate their attention around what this is, what it can do, how to make it work, and how to make it go again. So let me share that with you.
Look. Matthew, look. Wow. That's a lot.
A little apprehension, and then he looks right back at the tester. He points, vocalizes, and looks.
Okay.
He looks up, vocalizes again. So already at 12 months, before Matthew has any words, he is communicating with facial expression, with gesture, with shifting gaze back and forth between this object to make sense of the world around him. And it's very social, but there's also a cognitive piece to this. So this is a little girl who is not quite 3, and she's been able to follow my gaze to find the bunny rabbit. She's also not on the autism spectrum. And what I want you to notice is how when this bunny rabbit comes to the table, it's also the first time that she has seen the bunny rabbit, but she's in a slightly different cognitive place than Matthew. So instead of trying to figure out kind of what this is and how to make it go, we can actually share attention to some ideas. And she touches the bunny rabbit's nose and kind of jumps back as if it's maybe bitten her, but she knows she's not really hurt. And we have a little bit of some joint attention around a pretend idea. So I'll let you watch that. So we're having joint attention to symbolic experiences and to meaning and how to make sense of that. So keeping those two videos in mind, I'm now going to share a video of a little girl on the autism spectrum who has the same procedure. You'll see me try to draw her attention to the bunny rabbit. I want you to notice something really interesting here. It's not easy for her to follow my gaze. It's not even easy for her to follow my point, but she doesn't give up and she figures out another way. And the way that she does it is she lines her finger up geometrically so that it's spatially aligned with mine, and then she follows her own finger to find the bunny rabbit, which is really impressive because she does find it. And in a sense, she passes that responding to joint attention. It just took her a little longer, and it was more effort on her part. We bring the bunny rabbit back to the table, and keeping in mind the joint attention that you saw in the previous two videos, I'd like you to observe this little girl and see what you notice in terms of the differences.
Olivia, look! 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 Olivia, look! Look! Look there! What's that? What's this? Okay, let's go.
Okay, so what did you notice about Olivia in relation to the bunny rabbit? Anyone? Yeah.
She wasn't looking at you at all.
Okay, she didn't look at me, right? So there was none of that gaze alternating or joint attention. Excellent. And then what about the way that she connected or looked at or related to the rabbit? This is the object piece of it, yeah.
She had to put her head down and sideways till she would gaze at it.
So she was closely inspecting it. We'd put that on our list of restricted repetitive behaviors. Maybe she put her face up close to it. What else?
I wondered if she wasn't interested in the mechanics.
She was trying to figure out how it worked. Absolutely, that's exactly right, right? And so when I actually first put these two videos together, I was speaking at a conference where the speaker after me was an autistic woman, and I asked the same question, and she raised her hand and she didn't notice the joint attention difference, and that was the reason I originally put these videos together, was the joint attention difference. But she said, this little girl didn't realize it was a rabbit, and so she was trying to figure out what it was. And everything changed for me from that point forward when I put these videos together, because it's both. A, she didn't have the joint attention, but B, because she didn't naturally have the capacity to use me to tell her what this means, how to make sense of it, how to play with it, we can make sense of it together. She is then stuck, in a sense, with figuring out on her own. Well, so of course she's going to inspect it, she's going to turn it upside down, she puts her face close to it, and we start to say, oh, here we have a lack of central coherence, or, you know, a repetitive way of looking at the object, or systematizing. But of course, when she's not sharing the world with others, her way of understanding the world is going to be more fixed and more limited. So I think that if we look early in development, these features of the syndrome go together. I want to say one more thing about, yes, sure.
Is her style of inspecting that an indication of another kind of intelligence or learning?
Absolutely. You caught me on my last slide. My final sentence will address that, but absolutely, yes. So I just want to propose one more idea to keep in mind, that autism spectrum disorder is a syndrome. By syndrome, all we mean is a collection of clinical features that seem to go together. It doesn't say anything about what the cause is, and probably there are a variety of different ways in which young children who have challenges engaging with the social world go on to meet these features, but different children and different individuals can have different features within these categories, and so there can be overlap among people on the spectrum, and also a huge array of differences, both in original biological etiology and the pathogenesis, or how the condition develops. So now I want to skip ahead a little bit. If we're thinking about young children, what would be some of the red flags that we'd be looking for considering maybe some concern that a child should be evaluated or might meet criteria for this syndrome. So in young children, limited use of gestures and facial expression to communicate. So often I see families who are really anxious to help their children talk, and they feel like those words are the first communication. But if you think back to those videos where Matthew and the little baby were gesturing, moving their hands and their facial expression, there's a huge amount of communication that goes on well before a child says their first word. Reduced eye contact, it's not saying the child doesn't make eye contact, there's just less, and they tend to alternate gaze less frequently, less frequent social games and bids for attention. A reduced responsiveness to the bids of others. So if I were trying to call a child's attention to something or hold something up and show them, they may be less likely to look. And in some cases, about 20% of children who later go on to be diagnosed with autism, there actually has been some language development followed by a regression between the ages of 1 and 2 years. So I just want to show you how early the capacity to sort of read intentions begins, and how this is something that we're looking at in young children on the spectrum. This is my son Matthew in a Starbucks coffee shop in Germany. Actually, I was presenting at a conference and we went over to take a little break, and I was playing with him with his toys, and he's about 7 months of age here, which is a little bit before the joint attention that you would usually see. And I had been teasing him, and I held out one of his little toys, and then when he went to take it, I took it back, and I noticed that he was aware of what I was doing with the teasing, and he would look up at me. And so I put up my iPhone and took a little video of this. And you'll be able to see the look up to me. So this becomes a social game in that I'm offering it, and then when he goes to take it, I take it away, and he's aware that I'm teasing him, which means he's reading my intention, and he's only 6 or 7 months of age here. And yes?
Isn't, in terms of early communication, isn't lack of pointing response a really important flag?
Absolutely, but at this age we wouldn't even yet see the pointing, but yes, absolutely.
What age would that be?
Well, so that 10 months where they start to alternate gaze, they're also starting to point. In fact, I'm going to show you a video. Well, you'll see that about 12 months of age. Yeah. So on the ADOS, and I'll be showing you some pictures of the ADOS in a little bit, we now have, at this time we didn't yet have those, but we now have 2 assessments part of the toddler module that look at this teasing. And one of them, with the toddler who might be on the autism spectrum, you have a little shape sorter, and they're putting blocks in, and you're giving them the block to put in. And after they've done this a few times, you cover up the hole, you give them the block, and then cover the hole where it should go in. And what you see with most children is they'll look up at you and smile or laugh, kind of like what you saw with Matthew, or they'll look at you like, what are you doing? But they know that you are teasing them. And for a lot of children who end up with a diagnosis of autism, they'll just pick up your hand and move it out of the way, like it's an obstacle to their path of putting the block in. There's also a game we do with a bubble gun. We're spraying bubbles around the room, and then eventually the child often wants to try to use the bubble gun themselves, and so we'll offer the bubble gun and say they can use it, and then pull it back and smile. And often children on the autism spectrum, or who go on to have that diagnosis, will like kind of wander away or just try to get the bubble gun, or not even realize that you're teasing them, whereas a lot of children who don't have autism would look up at you and kind of smile at you or glance up and know that you're teasing them. So these are now tasks that we use in toddler assessments to see if the child may be on the spectrum. Another item on the ADOS is response to name. And again, remember, this is a person that Matthew's not met before who's learning the assessment. He's going to be playing with Matthew, and then he's going to go behind Matthew and call his name.
Matthew.
You see how immediate that is?
Wow.
Think about when someone calls your name. When they're behind you calling your name, what's that feeling like? It's something like someone's trying to get my attention, right? There's a feeling like of being called. And a lot of children who later go on to receive the diagnosis of autism on this assessment will not look at all after we call a few times. And then we ask the parent to try. And sometimes parents say to me, well, they don't respond when I call their name or it's inconsistent. And we say, well, try anyway. Let's see what happens. The parent will try a few times. And then we let the parent try to say something, and sometimes there's something they can say that the child will look because it's an offer of something the child likes. Sometimes the parent physically has to touch the child, and sometimes the child doesn't respond to the parent at all. But notice how fast it is for Matthew, how immediate it is to respond to someone calling their name. So I want to go back to your point about the pointing, and this is another item from the ADOS where the tester blows up a balloon and starts a little game where they release the balloon and let it go. And what you'll see, again, remember I'm in the role of Matthew's mother, and the parent would be in the room with the child when they're receiving this assessment, but I'm both the mother and the trainer here. And so when Matthew sees this really cool thing that's about to happen, he doesn't just enjoy it for himself, he points to it and looks at me to make sure that I see what's about to happen. So I'm going to show that to you, and that'll answer your point about the pointing. We call this a declarative point because Matthew's not pointing to ask for something, which would be proto-imperative, like, I want that, give it to me. He's pointing to say, look at it with me, let's share this. I want you to see it too, Mom. And that's a kind of pointing that even when children on the autism spectrum do point, they tend not to point as frequently to share experiences. Yeah?
Is Matthew very typical, or is he a little more relaxed because you're in a setting that...
This is very typical for what we would see. I mean, I'm just using a lot of his videos because he's my son, so I have permission to share them more easily. But in fact, in my graduate training, when I started my PhD, my mentor, Peter Mundy, who's now at the Mind Institute in Sacramento, so I came in having worked in autism for a number of years and was really excited to start to work in his autism lab. And then he said, no, you're going to work in the baby lab doing social communication with typically developing babies. And I was really disappointed and said, but I was planning to work in autism. And he said, you won't understand autism until you understand early typical development. And he was right. So yeah, this is very typical of young infants who are not on the spectrum. Okay, so here's what you would see with something like the balloon task.
Good boy.
So it's a give. And now it starts to blow it up. Matthew points and looks at me. Then he comes for a hug.
Yeah, look. Ready?
That's the gaze alternate. You see him back and forth between the balloon and the tester. A little gesture there. And notice that he brings it straight away to give to someone to request again.
Excellent. Thank you. Yeah.
A little apprehension that he directs to the tester.
Again. Again.
Okay, so just in that clip, if we were actually doing an ADOS and making some observations here, there's sort of 10 or 15 different things we'd be looking at. Like when Matthew's making that noise for again, he's directing that to the tester. So a lot of children might be just making noises, but he's directing it as communication. He's also giving to request. He's alternating his gaze often between the balloon and me or between the balloon and the tester. He points and looks back to share. And when he's a little apprehensive, which a couple of times he wasn't sure about it, he actually directed those facial expressions of apprehension to the tester and to me. So what we're seeing there, all of those would be aspects of what's happening in the ADOS that we would be coding. And then I want to move to the restricted and repetitive behavior red flags. So one of the areas that we look at are repetitive motor movements, also routines and rituals, intense interests, and unusual reactions to or interest in sensory input. And just give you some examples. So in terms of this particular item, we actually lump together repetitive speech. So kids that are saying the same sentences or phrases or words a lot, using the same, sort of sometimes you see children learn a few words, they're putting some words together, but they use those repetitively. Lining up objects would be a repetitive use of objects. You also see mannerisms, and we tend to think of flapping hands, but there's also some more subtle ones, like sometimes kids will pace or they'll spin in circles. Little girls will put on, they'll like to wear dresses and spin in circles to see the skirt twirl around. So sometimes the repetitive motor mannerisms are a little more subtle. Sometimes asking the same questions, even though you already know the answer, we would count that under repetitive language. Special interests, very interesting because some of these, maybe all of them, we could think about as passions or enthusiasms. And Matthew, like you could see, he's not on the spectrum, but when he was about 2, he was really obsessed with cows, and we had like 1,000 cows. Every time we went into toy stores, he would go to the plastic cows, and one day we were in a farm area with sheep, and I said, "Isn't this great?" And he said, "I don't like sheep, I like cows." So, I actually think a lot of toddlers do get passionate about their interests, and I kind of see what happens is a lot of kids that don't outgrow that, or they get more specific, or it gets harder for them to have their attention diverted elsewhere. That's where you start to get some concerns. And I recently assessed a little 2.5-year-old. He did end up with a diagnosis of autism spectrum disorder, but he would have been classic Asperger's if we still had that diagnostic label. And he knows how many moons every single planet has, and he will correct you and tell you the list of all the planets, how many moons they have, how many miles away they are from the sun. Amazing, right? And so I think when we think of children's special interests, sometimes we want to consider that these enthusiasms or passions or talents may go on to do amazing things for the world in the future. And we can see that if we look at people today, like the 15-year-old from Sweden who has Asperger's syndrome and is leading this huge international campaign against climate change. So we do want to think about special interests sometimes as being very valuable and areas to foster and develop in the children. At the same time, sometimes these special interests get in the way of their ability to engage with other things in the world. And I recently tested a little kiddo who loves plastic bottle caps, and he would like to carry them and have one in each hand and have them at the table. So that was his interest. And another little guy recently, the dad was telling me that he would tell him every single kind of dinosaur and was even teaching his dad the dinosaur names. So even though, for instance, a lot of little kids might like dinosaurs, the intensity, the specificity, the difficulty being redirected is what you'd be looking for. Routines and rituals. So here what you might see is that the child insists they always have to drink from the same cup, or they have to sit in the same seat, or they have to have a certain number of kisses before bed, and if they don't get that number of kisses, they have a meltdown. And so there's sometimes kind of a need to control the environment and also to control others, maybe insisting that other people say or do certain things in a certain way. If you disrupt the child's routine, sometimes that can trigger a meltdown. So a child who insists on always stopping in the same places at the same time after school, or taking a certain route to school, and then you change that, or things are different, or you stop them in the middle of something they're doing, and then that meltdown is really different from a child just having a tantrum because they're not getting their own way. In this case, it's kind of like their whole world has fallen apart, and it's really challenging for some children to deal with even what seem to be minor transitions, or something like changing the layout of the furniture in the living room can trigger a really big high level of distress. Tested a family recently with a little toddler who liked to take all the rocks out of the back garden and line them all up, and whenever the parents would move the rocks, she would just go get them and bring them back and put them in the same places all over again. So atypical reactions to sensory input, I think this is a really big one, and it's important to note that a lot of kids have difficulty tolerating sensory input or have sensory abnormalities that may not meet criteria for autism spectrum disorder. Sensory processing disorder came this close to making it into the DSM-5, and it didn't quite get there, but the research is now really coming in to suggest, you might see a lot of sensory symptoms, and at the end of the day, it's not autism because you don't have the joint attention impairment, and I do see that a lot clinically. But here you might have kids that are overwhelmed by loud sounds, like the sound of the blender, the hair dryer, the vacuum cleaner. They're manageable and tolerable to most of us. To some children on the spectrum, these can be very distressing. Things like peering really closely at light, or like the light reflections through the window blinds, watching fans go round and round. Maybe light or sound are aversive. So these are different ways of reacting to sensory stimuli. I want to point out, and some of you, I know there's a lot of family members in here, and you might have experience of a young child in your family or that you've worked with on the spectrum who's really challenged by everyday activities like brushing teeth, having your face washed, having your hair combed, or getting your nails cut, and those can be very aversive and challenging because of the amount of sensory overload sometimes associated with those experiences, and so you can get meltdowns around those issues. So I want to say a little bit now about the assessment process. What's really important with assessment is that the professionals involved in doing the testing are experienced with autism spectrum disorder, because a lot of these features I've just spoken about can sometimes be features of being a toddler, and sometimes they might reflect other things going on, like attention deficit hyperactivity disorder. A child may be highly anxious. I've seen children come in where the diagnosis is actually selective mutism and not autism spectrum disorder. It could be a case of a comorbid diagnosis like autism spectrum disorder and other things happening. And so experience with autism is really important. Also important are observational measures. So the ADOS, which I've just been saying a little bit about, and I'll say more about that in a minute, is one example of an observational measure, and there are others. But the ADOS comes in a big kit like this with all these different toys, and it's actually a series of presses or social situations that you have with the person being assessed. I've focused today on toddlers just because of this sort of birth to 5 focus here, but I just want to highlight for you, these are some materials that would be in the toddler module, but you also have children who are a little older that aren't yet speaking. You have children who speak in phrases but not yet complex sentences. So a lot of times a 3-year-old or a 5-year-old might get a module 2. Like a module 2, the child might be speaking in short sentences, but they have a difficult time having a little conversation back and forth. So you make a statement or you ask a question, and they don't respond to what you said. So they'll say things, but they're not able to really sustain a conversation that's social. In the module 2, you might ask the child to engage in some pretend and make-believe play with you, and you ask the child to engage in some activities like showing you how they brush their teeth. You're looking at gesture. So here with the module 2, you're asking at a higher language level for the child to demonstrate their social engagement and flexible thinking or pretend play. We also have a module 3 for adolescents with fluent speech. Here you might be asking questions about the child's social experiences, emotions, friendships, relationships. You still do some play, but the way that you set it up is more manageable for, tweens and adolescents. And we even have a module 4 for adults with fluent speech, and here you'll be asking about work or school or career plans and social relationships. And here you're not doing pretend play, but you actually have a little bag with objects that you take out that you make up a story with, and there a lot of people who are on the spectrum have a hard time with that level of imagination. So I just wanted to highlight that the ADOS does go up to these different levels. The other thing that you would want to be assessing when you're doing a diagnostic evaluation is cognitive ability, because somebody on the autism spectrum can also have intellectual disability, they can have normal IQ, and sometimes they can be highly gifted, and you need to know what's the intellectual ability of the person, because being on the autism spectrum or not, it has nothing to do with how intelligent you are. And also, sometimes people on the autism spectrum have very, what we call spiky patterns of intelligence, where there are areas like processing speed might be really slow, but they may be gifted, they just need more time. So you need to know that profile. We also test for language, so speech and language therapists might do some language testing to see if there's a language disorder. And on top of that, it's really great to have an occupational therapy evaluation so you can look at what the sensory processing needs are and also adaptive skills. When we assess for the diagnosis of autism, at this point, we really look at it in a very dimensional way. And so an individual can have a mild degree of autism symptoms, or they can be very severely affected, or somewhere in the middle. We look at this in terms of how much support does the person need. And when we do this evaluation, somebody could be at a level 3 requiring a lot of support for social needs, but a level 1 in terms of the repetitive and restricted behavior, or the other way around. So we assess what's the degree of impairment in terms of autism spectrum disorder in both of these domains, and then we say with or without intellectual disability, and also with or without language disorder. So even though we no longer have different categories, there's a bunch of different dimensions that kind of intersect. So in terms of the assessment, one of the things I want to wrap up with on this point is we also interview parents. We need a developmental history. Hopefully we have input maybe from teachers or school visits if that's relevant. And so we're actually, what the clinician is doing is gathering a lot of information together. There are checklists to see what are the child's developmental abilities or skills in all kinds of areas of their life, from self-help to all kinds of ways in which they might function adaptively in the community, at home, and at school. Their functional academics, not just how bright they are, but kind of how they're doing with academic tasks in the day-to-day environment. Once we've done all of these assessment measures, the clinician is really making a judgment about whether or not the child is on the spectrum. And they're pulling together all of this information and using their best clinical judgment. None of these assessment measures in and of themselves tell you if the child's on the spectrum. So sometimes people walk away from hearing about the ADOS and they think this is the test that tells you if it's autism or not. That's not the case. It's the individual doing the assessment that uses information from the ADOS as one source of information that's valid and reliable to help make that decision. At the end of the day, what's the point or the goal of assessment and diagnosis? I think we have a few aims here in having a child assessed and diagnosed. One is understanding and accepting your child. So when you understand that maybe your child has sensory overload, or this is the way in which they're processing the world, it's much easier to help them when they're having meltdowns or they're struggling in school, or they're biting peers or not listening to you. Suddenly you can actually see it from their perspective, kind of what life is like, and gain a better understanding of the child on the spectrum. There are also a lot of early intervention opportunities that we have now, and as a professor at Sonoma State, I'm now getting the benefit of seeing adults on the spectrum as my students who have benefited from years of intervention, and it's fantastic, and we think we're on the cusp now of seeing a lot of adults really making it out into the world, having had remediation and therapy, just to help them in ways that make it easier for them to communicate with others and to have success in multiple different environments, including academic. Having that evaluation can be really useful for placing the child in the right school and educational setting and getting the services, support, and accommodation needed. But at the end of the day, I want to come back to this gentleman's point, is that Originally autism was sort of thought about as a rare disorder, and we had a very limited understanding. As we broaden and loosen and open up to understand these dimensions, we actually come to realize that all of us vary along these different dimensions, whether it's sensory or special interests or how we communicate socially, where our passions are. We're all somewhere in those dimensions. And as we open it up to sort of appreciate how many of us qualify for the syndrome of autism, we don't always have to think about it as a disorder. Ultimately, this helps raise awareness that in this world we have all kinds of minds, and so we can be more accepting of neurodiversity. And so I'll end on that note. I don't know if I have time for questions. Thank you.
And then I'll pass this. Are there questions for Dr. Hobson? We'll start here and I'll get back to you.
One of the last few slides, you had the 3 functional levels of, is that something new?
Yes, in 2013, the DSM-5 came out, and instead of having a whole bunch of different disorders, so we used to have high-functioning autism and Asperger's disorder and pervasive developmental disorder not otherwise specified, we had the problem with all those categories is that one child could go to one psychologist and be diagnosed with Asperger's and another with high-functioning autism and another, they weren't reliable. So they put all these categories together, and then they said we have these 2 dimensions. One is severity of autism, and then the other dimension is intellectual ability and kind of functioning. And so what used to be Asperger's is now high verbal ability, high intellectual ability, and the level 1, mild autism spectrum disorder. So we look at it dimensionally. Yeah. And that is new since 2013, but still people are learning to think in that way. And often when you use the word autism, the picture people have in their mind is more intellectual disability and kind of level 2 or 3. So we often don't recognize the level 1 intellectually able individuals as falling under that diagnosis, which is now autism spectrum disorder.
Thank you.
Mm-hmm.
So questions? Oh, boy.
You may have really addressed this already, but a question that I had was, is there any chance that this diagnosis could be triggered through the social, emotional environment, through parenting, through trauma?
It's great that you asked that question, because one of the unfortunate pieces of the history of autism spectrum disorder was reference to parenting. And so I do want to clear up now that it's biological and genetic, in that probably the initial causes are already there even prenatally that place a child at risk. That said, there are severe situations like in the Romanian orphanages where a child has no possibility of engaging in joint attention that we do know lead to onset of the syndrome. And also when there is trauma for young children, you can sometimes see a lot of features. And I see children coming in diagnostically who have been exposed to a lot of trauma as infants who actually end up not getting the ASD diagnosis, but who have a lot of features. You could also have a child who was vulnerable neurologically and had a trauma history that probably could make the symptoms worse. So I think there is a developmental progression, but it's important to note the initial causes will be biological and often genetic.
Okay. Other questions back in this area? Here you go.
We have an interesting situation in my school at Bahia Vista of a selective mute. Is that a form of autism, or is that something totally different?
So selective mutism is actually an anxiety disorder, and the anxiety will make it very challenging for the young person to speak. In certain situations, they'll often speak with one or more people that they feel very comfortable with, sometimes just at home and not in other places, but it's not intentional, it's severe anxiety. Now, you could have autism and selective mutism, so they could be comorbid. But you can also have selective mutism where autism is not a diagnosis at all. And that's where a clinician that kind of knows what they're looking for in terms of the criteria would be important for the assessment.
Thank you.
Thank you very much, really informative. I want to ask a question. If, in treatment or interventions, the data show that people with autism who have higher intellectual capacity are more able to advance, become, through the therapeutic interventions than people with lower IQs.
Yeah, I think that's an important comment to address because between birth and 5, 90% of brain development is happening. So I don't think IQ tests are very stable if you look at like a 2 or 3, 4-year-old. Really important to just keep in mind that the brain is under so much development and there's so much plasticity that intervention itself could change the IQ and when you're looking that young. At the same time, we all know, and this is true for people without autism as well as with autism, some people process information more quickly, learn more quickly from the environment, and so not everyone is going to respond in the same way. And that's also important to keep in mind for the types of intervention. Not every child responds well to every type of intervention, and sometimes it's a matter of finding the best fit that really is a place where your child will make gains, and it's not going to be the same for everyone. Thank you. Thanks,
Suzanne. In this excellent handout from the Marin IJ, it talks about 59 kids being diagnosed with ASD. The last time I heard this lecture, which was about a year ago, it was 1 out of 84. So question, what's going on? It goes from 1 to 59, from 1 to 84. Question number 2, is there anything to do, or the second question was something about girls, 151 girls versus 37 boys. What's the deal? Why do girls get diagnosed so much less than boys?
I'm going to start with your second question because this was the subject of an entire conference that's ongoing, organized by Karen Kaplan, and I was a speaker there, so it could take hours to address that. But the short answer is we think actually a lot of girls are underdiagnosed because the boy model of autism is based on a lot of boys that we've been seeing, and girls, sometimes their special interests are things like dolls or My Little Ponies. They have a different way of socially fitting in and camouflaging. And so a lot of the higher functioning, more intellectually able girls have been underdiagnosed. We think that's a part of it, although a part of it can also be there are genetic differences between boys and girls where there may be some more vulnerability. So it's a mix of those two. In terms of the increase in diagnosis, we think probably 2 things. One, increased awareness and a broadening of the diagnostic criteria is a part of it. Secondly, there are a lot of both genetic and environmental factors that are leading to increases in a range of neurodevelopmental disorders, including, for instance, attention deficit hyperactivity disorder is now diagnosed in about 12% of boys. So we're seeing more neurological and neurodevelopmental vulnerability. But I think one of the main reasons for the rate of increase that we're seeing is probably, at least recently, that the diagnosis is broadening and that autism has always been with us and there have always been people on the spectrum. We just didn't label them with that label.
From a public health standpoint, about 5 years ago when we looked at this, there was a big issue about EMF, electromagnetic forces. Pregnant women using cell phones or having cell phones on their body with the brain EEGs lining up when they had cell phones with males, an Israeli study about Israeli males who had cell phones on their body and the sperm count went way down. Is there anything about EMF and cell phones, anything about these G5 businesses that translate into pregnancy and autism? There must be a reason why the rate has gone so. To me, it sounds like it's epidemic, but again, I'm not that familiar with.
I can't comment on that specific factor, but I can say that there are a range of environmental factors like living closer to a freeway, older age of parents, all kinds of things in the environment as well as biologically and genetically that probably increase the likelihood in more neurologically vulnerable infants and in prenatal development. So I think we need to take seriously all these possibilities, and it's not going to be one thing, it'll be a range and a mix of factors that interact. Yeah.
Okay, one more.
You'd expressed concern about covering a lot of material in a short amount of time. You did a marvelous job.
Thank
Thank
you.
you.
Thank
I have one suggestion for you to consider. In this last sentence, change the word understanding to appreciative.
you. Oh, I love that. I'll change the slide right now. Thank you so much.
Thank you, Dr. Hobson.
Thank you.
And thanks for your patience. I didn't want to cut her off. It seemed like really important information, but we'll adjust and we will finish by noon. And we're continuing now with Alicia Prather from Golden Gate Regional Center.
Good morning, everybody.
Morning.
Can you hear me on this? Great. Thanks for having me. I am from Golden Gate Regional Center, GGRC, and we are one of the regional centers here in California. And we have 2 programs that we run. And what I am the supervisor of is the Early Start program for Marin and San Francisco counties. Who here has heard of special education? Right? So Early Start is actually part of the IDEA, the legislation that covers special education. The other program that we have is the Lanterman Act, which is a California-only law, but special ed is federal. So we deal with a lot of legislation, a lot of restrictions, and it can be hard for us to provide services sometimes for the community because of these restrictions that we deal with. So if you have, or you know, or you work with little ones between 0 and 3, you are welcome to refer them to to GGRC. And we will do a complete developmental assessment on them. Whatever your concerns are, please let us know. A lot of our referrals come in as perhaps a speech delay. I'd say it's our most common situation. If you also have concerns about the poor eye contact that we were talking about, it would be really great if you could let us know so we have a better assessment team ready to roll and work with you. So, sorry, this was a little last minute for me. So our eligibility criteria is that an infant or toddler is 33% delayed in at least one area. That might be communication, that might be gross motor skills, fine motor skills, social emotional concerns. Once you are found eligible, we will work with you to develop a treatment plan, a service plan. However, due to these legislation rules that I mentioned, we cannot fund services until you first try generic resources. Usually that is your health insurance. Even if there's a copay, even if it's out of the way, the law requires us to do that. What happens a lot is that the insurance providers limit the number of sessions. Perhaps your child is eligible for speech therapy or ABA therapy. They might limit the number of sessions, and once you've gone through those, then we can look at putting those same services in place. It's not because we don't want to do it at the start. We know that a continuity of care is the best way to treat kids, whatever's going on with them. It's just we're not always able to do that. Another situation that happens is the insurance providers don't have enough therapists. ABA particularly, who's familiar with what ABA is? Okay, most of you. It is applied behavioral analysis, and it works It's used mostly with kids who are on the spectrum or suspected of being on the spectrum. And to back up, we don't need a diagnosis in the Early Start program to provide services. If we see early red flags of what we think might eventually be diagnosed as autism, we will proceed with the treatments that we feel would best treat the situation. But what we're having a lot of problems with, I think it's our wonderful economy, is finding providers, both the insurance companies and ourselves, finding people who can provide the services for so many kids that we are working with. So if you do have a good insurance plan that does cover these things, but they say, I'm so sorry, we have a 3-year wait list before you can get services for your child, let us know and we will work on that. And hopefully we will have the resources to do that because we're facing the same crunch as well. Let's see. Our services do end at 3 years old. And at that point, we will help you transition to the next steps. The 2 biggest next steps are your local school district or county office of education and our other program, the Lanterman Act. It's very confusing for everyone, ourselves included, because GGRC does have 2 programs under the same roof. We do not. If your child is eligible for Lanterman Act services, those are totally different services than what you may have been receiving from us. Naturally, you think, oh, I can keep getting the same things. That's not going to be the case. The everyday services that you may have been getting, hopefully based in your home, if we were able to, Marin is such a sprawling county, we may not be able to find somebody who's willing to drive to Stinson Beach to, work with you, so you may have been coming somewhere for services. But those same everyday services are now going to hopefully transfer to your local school. Special ed at that age, 3 and above, has its own set of eligibility, their own services that they're going to provide. It's not going to be a seamless transition, but it is what we have. Also, with Lanterman Act services, this is where a diagnosis is necessary. Not only does somebody have to be found to be on the spectrum, we talked about those 3 levels. It has to be at one of the higher levels. I don't work in that program, so I am not going to get into the nuts and bolts of what that might look like. That's just beyond my scope. For many of our little ones that do become eligible for Lanterman Act services, there's not a whole bunch that happens at an early age. It's a lifelong program that provides support the whole life long. The example I give is my cousin. She has identical twin boys, now in their 20s. They were both diagnosed with autism very young, one with Asperger's at the time, the other with intellectual disability as a comorbid condition. They both had early start programming, IFSPs. They both went to special education after that, but only one is eligible for Lanterman Act services. The other is slowly but surely taking classes at CSU Hayward. Very different situations. So that's just kind of the overview of the programs, services that we offer. Anyone can refer. Anyone can refer. It doesn't have to be your pediatrician. It can be you. It can be a concerned grandparent. It can be a daycare provider. Okay, so please refer any kids that you know about, and let me know if you have any questions.
Thank you. Are there questions related to the Golden Gate Regional Center?
Hi, my question is how to help families not access the services, but when there's resistance or they don't see what you might see, and how do you respectfully help families along that path? Or if you have any suggestions.
We deal with that quite a bit. It's hard. It's a voluntary program unless a family's involved with CPS, and that's mandated, but we don't police that part of it. Like with all social work type of things, you have to meet somebody where they're at. So when I was a service coordinator, I encountered this several times where a mom just kept saying, he has a speech delay, the speech therapist is coming over. These were ABA therapists. So for her, she could accept the services as long as we let her get away with calling it something else. Fine, for now, we'll take that, and by the time she transitioned to the school district, she was more on board. It's just hard. There's no one way. You don't want to scare somebody off, right? So we want to try and serve the kids the best way we can. And if that means they're only going to take some services and not others, so be it. Or we call it something else for the time being. That's what we're going to do.
Other questions?
So in terms of the costs of who pays for the services and at what level, what impact is there on school districts who have children who require more help because they're in the school district mainstream, but they need additional services?
You know, I'm not really familiar with the school district funding, and my assumption would be that it's covered by special ed and up to the federal Department of Education.
And we'll get to school district issues next. Anyone else? Great, thank you.
Thanks.
Thanks very much, Alicia. Thank you. We're going to continue on with Christina Fass from Marin County Office of Education. And do you want to, is that okay? Great, thanks.
So, I know, and I'm short, I have to go on my tippy toes. Thank you, everyone, and thank you, Alicia, because it's a great transition from early start to school-based services. And with that, we're transitioning from early start to early intervention services. And primarily the responsibility for early intervention services for children who are age 3 to 5 fall on the school districts and or the county. And one of your handouts that you have that explains the early intervention program in Marin, which Marin is unique in that it's a small county, but there are 18 different school districts within Marin. There are school districts that operate their own early intervention program, and then there are school districts who partner with Marin County Office of Education to operate their early intervention program. And upon a child's 3rd birthday, the student transitions from Part C to Part B program services. We are also governed by IDEA, which is right now, I have to point it out. I have anxiety and my heart is pounding so hard. And so I have a hard time with my expressive language. Individuals with disabilities, I don't even know, Education Act, yeah. And that legislature, which is federal, governs schools, and they must provide a free and appropriate education within the least restrictive environment for students. So when a child is turning 3, there's a process where we go through the GGRC transition process, where we meet, that table over there, I meet with many of them, to talk with parents about how services change upon the child's 3rd birthday. Yeah.
Sorry to interrupt you. Could you be back a little bit?
Oh, sure. Yeah.
And you can even push the microphone to the side if you want.
Oh, actually, I can go down so I don't have to go on my tippy toes. Yeah, I'm sorry. Like I said, I'm a little nervous. With that, services shift from home-based services to more school-based services. So it looks different. And when we meet, oftentimes there's 13 areas of eligibility for special education upon a child's 3rd birthday, one of which is autism. We have different criteria than the medically based DSM-5. Ed code, we have our own different eligibility that we look at with our assessment. And typically, if a child has concerns in the areas of autism, we typically do a multidisciplinary assessment utilizing a school psychologist, a speech and language specialist, as well as an occupational therapist. I'm speaking on behalf of Marin County Office of Education. Most of the districts, San Rafael, Mill Valley, Novato, who run their own early intervention program and plan out their own assessments, typically do a multidisciplinary assessment as well. And upon a child's 3rd birthday, we look at that eligibility to determine, is the child eligible for services? Based on the eligibility criteria, if a child is eligible for services, they're eligible. And what type of program do we provide for that student? Well, like we mentioned, autism is a spectrum disorder. Therefore, we have a spectrum of services. Schools are governed by providing a free and appropriate education in the least restrictive environment. That legal jargon just means we want to provide an education that meets their needs while also providing them the most exposure to typical peers. So with that is, if a child's eligible, that assessment, where I look at the assessment, where it's important, is it identifies areas of need, which then the assessment team proposes goals that meet those needs, that address those needs. And those goals drive the recommendation of that assessment team on the program that is provided for that student. For Marin County, we have a spectrum of services ranging from speech and language to special day class programs, which are focused on teaching students with autism. Our programs, Marin County Office of Education programs, our framework for the special day classes that focus on students with autism, we use a CERTS framework, and that just means we use evidence-based interventions that focus on social communication and emotional regulation. CERTS just stands for SCERTS, social communication, emotional regulation, transactional supports. That means if you'd walk into a special day class that is located at Marindale, that's our location, you would find evidence-based interventions within that classroom that is building up social communication and emotional regulation. Because a lot of research has shown that those are 2 areas that later predict greater success in school and life. And then, so that's age 3 to 5. If a child isn't identified prior to age 3 by GGRC, we do take parent referrals. We often do. Children who haven't been identified with concerning red flags until after the age of 3, and the parent needs to call the school district, call the county to make that referral for an assessment for special education. Again, we use different criteria to determine eligibility. We have a school-based model looking at education versus a medically based model. And then when we're thinking about children who are transitioning to kindergarten, age 5, their kindergarten age for the next fall, we look at school-based services. So programs from kindergarten to potentially age 22, based on the needs of the student. Upon the child's entrance into kindergarten, we do a kindergarten transition meeting. We meet with all the parents in spring to get an updated assessment of needs, present levels, looking at their progress on their goals, and looking at, most importantly, what that assessment looks at is the child, I'm sorry, I keep going close to it. Sorry about that. I don't know why I need to hear my voice so loud. We're looking at, is the child still eligible for special education? That's the small piece. Most importantly, that kindergarten transition assessment and meeting will discuss what is this child's areas of needs. We're going to propose goals for those areas of need, and that again drives the recommendation of what that service will, how the individualized education plan will look. What will be the school plan for this child? And again, the plan can vary depending on the unique needs of the child. And again, like we mentioned, autism has a large spectrum of unique needs. Every child is different. So when I think of describing our program, we have to be flexible and adaptable. And I'm going to get back to school-based services, but I look at it as our program changes on a yearly basis. Because if kids are turning 3 throughout the whole year, and we get referrals from parents throughout the whole year, and our program has to adapt for each student's individualized education plan. That said, is all of our programs, they're classrooms. They look like preschool classrooms, but they're not, they're intervention. And so we need to basically look at each student's unique needs and transform in order for those individuals, if that makes any sense. And going back to when a child turns 5, typically they might return back to the district because again, we want them to go back to the least restrictive environment. Depending on where they're at, if they're in the county early intervention program, we do the kindergarten transition assessment. We invite the district rep because they might be going back to their district and they might go to general kindergarten with support services, speech and language services, occupational therapy services. Again, it just depends on that child's needs. And another handout that I thought might be helpful is the list of the 18 different school districts in Marin. So there's 18 different school districts. And based on that, many of the school districts partner, again, with Marin County Office of Education for students who have moderate to significant educational needs. They need a more supportive environment. And all of our programs that serve students with autism that are school-based, with the exception of when they're 18, are on comprehensive school sites. So mainstreaming is a component of that child's program. And again, Marin County operates programs for the kids who probably are on that more moderate to significant impact in terms of when Dr. Jordan was explaining autism. Their educational needs are more significant than a student who can go back to district. I think that covers it. And thank you for your patience, because truly my heart is pounding, so I get nervous. I don't know why.
Thank you, Christina. If it makes you feel any better, I had a student friend one time that did her whole presentation holding her left leg up, standing on one leg because she got so nervous about what she was doing.
Yeah, well, no, I was kind of going on my
We want to take a few questions about school-related issues, and while we do that, can you just address the issue of private schools and parental choice, or when the district or the Office of Ed might refer children to private schools?
Well, typically, we call them non-public schools, and that would be dependent on an assessment. Assessment always drives recommendations, and it would be based on the proposed goals, based on those areas of need identified via that assessment. And if the district and/or county would not be able to work on those goals in that educational environment, that's where we would refer to, because we call it a more restrictive environment. It's farther away from their typical peers in their neighborhood. So it's, because oftentimes they're not on a comprehensive school site, they're a standalone. So it would be driven by an assessment.
Based on their
data.
need and based on what you're prepared to provide?
Yeah.
Okay. Are there questions related to K-12 schools, 3 to 5-year-olds?
We recently saw what took place in Oakland, and one of the major things, the people that they were getting rid of to be able to give the teachers a raise, et cetera, which I'm sure they deserve, was getting rid of psychologists. And it seems to me that the funding for education and everything to have no psychologists and totally abrogate what we're talking about today is absolutely ludicrous. Do we have the funding here in Marin, and why would they be taking it away anyplace?
No pressure, Christina.
Yeah, no, it's a really good question. I mean, it's a good question. I would say that Marin County is well equipped to address the needs of the students, and they are doing everything they can in terms of providing enough support staff for teams, school teams. That said, I think it's a broader question in terms of our educational system in general. So I don't think there's an easy answer. But I think Marin County, I can only speak on behalf of Marin County Office of Ed and the services that we provide on behalf of the school districts. And in Marin County, we have a behaviorist, which is unheard of in some school districts. We have school psychologists like myself. We have counselors. And I think that in Marin, it's not perfect, but we're better equipped than some other school districts.
Thank you.
Great. Other questions?
1 out of 59. How many kids do you have, and how many does this affect here in Marin? How many kids are there with ASD here in Marin? And do you have a ballpark figure, 1,000, 2,000?
In terms of how many students are in special day classes?
Yeah.
Well, I can't speak on the districts that operate their own special day classes. I'd have to run the numbers. I could probably give you a general term, but I can give you a number for students in the Marin County Office of Education's special day classes, and it's approximately probably around 90, 100.
And we have another question here.
But I also want to say that those aren't all special day classes that are for students with autism, because we also have special day class programs that meet other educational needs, because there's certain areas of eligibility, not to mention above and beyond autism. So that said, if we were looking at just early intervention or just the special day classes for the students with autism who require a Marin County Office of Ed program, actually that would be about the same, 80, going up to school age, so 18. So probably, well, I would say probably 120. I'm ballparking it, so don't quote me, because this is just in my head running the numbers.
I just had a comment. Up until age 3, typically, your children are having home visits, where people come, you can get these services. Once they transition, maybe lost in this conversation, and I think is critical, is that for the first time, they're interacting with other kids. And I think their social skills are truly enhanced by your programs. and in the school. And I think it's just worth mentioning because to me, I see changes in my grandson in the time he's been there, and just appreciate that point. That's huge, you know. It's the first time they really get to interact with other kids.
That's wonderful, thank you.
Thank you.
I have too many questions. So you talked about that the Office of Education used different criteria or for assessment than the medical assessment. And can you tell me why there isn't some why they have two different models?
Well,
And what difference does it make in the provision of services?
Sure, it's legislated by our federal government, IDEA, which when you go from Part C to Part B services, it's basically federal legislature. And the idea is, which is hard also as a child ages up, it transitions from home-based services to school-based services because school districts are responsible for providing that plan for the student. And it's governed by federal IDEA. See, why? Here, maybe if I read it. I got it. Individualized with Disabilities Education Act. Yeah, it's funny.
Okay, other questions? Thank you, Christina. Thanks very much.
Oh, there was
One here? Was there another question? One more.
My question is, what about kids who are assessed and don't quite meet the criteria for school district services? Because I think I see a lot of kids who aren't quite in that, 20, 30% delay to be covered by the school district, but then they kind of just don't get any services. So I'm wondering what you do to help those families whose children are assessed and don't qualify for your services. What do you do with those families?
Oh, that's a great question, and we use different criteria than GGRC. So we don't use the 20 or 33% delay. If it's a speech and language disorder, they have to be below the 7th percentile. But really, it's just I can only speak as one of the team members of an assessment team as a school psychologist. What I try to do is point the parent point them to community-based resources and education. It's the harsh reality. We all have these rules that we're bounded by and restrictions, and it is hard because we're in this, I'm in this to help, and it's hard. Okay.
Thank you so much.
Yeah, thank you guys. Thanks for your patience. I appreciate it.
Thank you. We're going to continue on with Karen Kaplan, and while she's getting set up, I just wanted to mention a couple things. We have an event page for this event. Marin Communications Forum is on Facebook, and for each event that we hold each month, when we create the event, I've been posting news related to that subject. So if you would like to see a series of news articles, research, and other information, if you go to facebook.com/Marin Communications Forum, on the left side, there are events, and you can select the autism event, and there are dozens of news articles there. Two of the most recent ones, Dr. Hobson mentioned the Mind Institute. That's at UC Berkeley, and they just had big news come out last week related to prenatal vitamins. There was a study of high-risk individuals and the finding that use of prenatal vitamins reduces the autism recurrence for high-risk families. So like for a second sibling, if the first sibling has been diagnosed. That was big news. And they have, their website has a lot of information, which is not on your resources. So To reach the Mind Institute, the address is health.ucdavis.edu. I can provide that for you afterwards. The other big news that came out recently was a study of 650,000 children in Denmark, once again confirming that vaccines, specifically the MMR, the measles vaccine, is not linked in any way to occurrence of autism. So there's obviously ongoing research, but really news coming out every day on this subject. Good?
Hi.
Good timing. Okay, Karen.
Yeah, why doesn't everybody get up for a minute? I can't do all this. Let's see. Everybody get up, stretch your arms way over your head to the left, to the right, jump up and down a little bit, stamp your feet, take a huge breath in, and just let a big sigh out. Now, that's pathetic. Try that again. Big breath in, large breath out. Okay, now you can sit down. Two things. So I'm Karen Kaplan. I know some of you in the room, and I don't know others of you, so I'm really happy to be here. Foundationally, I'm a speech and language therapist with my special education credential as well. Have worked in both public schools and those NPSs, which is a non-public school, which is like a private school. We all have a private school license, and then we're certified by the State Department of Education to provide K-12 for special ed students. Some of us work with mild to moderate kiddos on the spectrum. Some of us work with more moderate to severe kids on the spectrum. But I've been spending a lot of my life founding and directing schools for children with autism. I currently am the executive director at Wings Learning Center, a school for 42 children on the more moderate to severe in Redwood City. So I also, just to give you a little bit of background, founded and ran and directed a residential center for children with autism, taking children out of Napa State Hospital for 20 years. So, one thing I do want to say is I am happy to share this PowerPoint with any and all of you. My card's out there, but if you do Karen Supports You at Comcast.net, I'm happy to send it to you because it's got lots and lots of resources that you're going to see very quickly flash in front of your eyes. So I'm happy to share with you. Just let me know. Strange, two-fisted. By that can't cross the midline. Okay. So Helen Keller is my mentor. I was a little girl and watched The Miracle Worker, the film, and said, oh, I want to be Annie Sullivan. I want to be her teacher. And so I love the words that she has to say. And she says, alone we do so little. Together we do so much. Right? Here we all are. And the other one that she says is, the only thing worse than being blind is blind is having sight but no vision. So together with vision, right? Together with vision, we must support the families who love and embrace someone on the autism spectrum. So a bit of advice for us professionals, and definitely for us who are parents, you need to secure your face mask first. The airline's attendant always says that. I think that it's really important for you parents and for us professionals to have parents take care of themselves so that they can take care of the complex needs of their child who is living on the spectrum. Can you see? I'm not. Okay. How many of you parents know the story of I was planning a trip to Italy and I ended up in Holland. This is a story that has been in the special needs community for a long time. And it's all about a mom and dad, and they're getting ready to go on a trip to Italy. And they have looked in lots and lots of books, and they have found the sites they want to see. They found the directions to what they want, to get to those places. They're really excited about getting to Italy, and they pack their bag, and they've got all the right clothes that they need to go to this place, and the weather, for the weather, and all these activities. And they get on the plane, and they journey along, and finally the pilot says, "We have landed safely in Holland." And the parents are shocked. Well, wait a minute. I was going to Italy, and I'm in Holland? I don't know if I'm dressed correctly. I don't know what activities I have to engage in. I don't have any knowledge about this Holland, right? So the parents are shocked. They planned to have this child who was, going to go to kindergarten and first grade with everybody else, and was maybe going to get married or first graduate from high school and college and graduate. And all of a sudden, they're told, "I have a child with autism." And so it's known that they could feel sad and guilty and angry and confused and anxious and worried and lost and isolated. And maybe all of those at some point during the journey. So I have this whole thing about everybody, all of us sitting in this room, needs to have a full-up apple barrel. Okay, and what does that apple barrel signify? Yeah, it's an apple barrel of wellness. Each day, each week, each month, I ask all of you, and especially parents who have special needs kids, and even those with autism, to fill that apple barrel up. And each apple represents one of these things and more. So get good sleep. Oh, good, I got an apple in my barrel. I'm going to have healthy food. Yay, I got another apple in my barrel. Exercise, find time alone, find spouse time, find friend time, and ask for help if you're a parent. And there's a million other things that you can relate to filling that apple barrel up. But a lot of our families' apple barrel is empty. Sometimes professional apple barrels are empty, right? We didn't keep filling them with those wellness apples. We kept giving our apples away. We didn't get a good night's sleep. No time for friendships. Stress of those individual education planning meetings, doctor appointments, work demands, other siblings in the family. And when you begin to give all those apples away and you begin to see the bottom of the barrel, then as a parent, you don't have the energy to problem solve well. You don't have the energy to give your spouse what your spouse may need. You don't have the energy for your other siblings. So please, as a professional, help these parents keep that apple barrel full. And as parents, take time to fill your apple barrel. So, first is wellness, right? I mean, that should be the foundation for everything. We should be helping families develop wellness. The next is we should help families understand their child with autism, right? So I have a favorite book. It's my new favorite book on autism. And it's called Uniquely Human. And Dr. Prezant says, this is an important read for parents and professionals to help them understand autism and move above. This is critical to me. Move above seeing behaviors as just signs of autism, but to see behaviors as strategies to cope with a world that feels chaotic and overwhelming. We're so busy saying they have this behavior and that behavior and another behavior. An important read for both parents and professionals to direct their attention more at enhancing abilities, building on strengths, and offering supports that would lead to more desirable behaviors and better quality of life, rather than just curbing or stopping behaviors. I'm tired of hearing that. This is Uniquely Human. You could get it on Amazon. It's a great read for all of us. So in Uniquely Human, he asks us to ask why. And as I always did as a little kid, how come? How come? How come why? And then to also listen to our kiddos on the spectrum. And as Dr. Hobson says, see obsessions as enthusiasms. I love this. Because when you look at obsessions, people want to curb that behavior and get rid of it. But when you look at it as an enthusiasm leads to an interest, leads to the way you can incorporate that enthusiasm in teaching as a teacher, right? Or in developing that interest as a career. But when you look at it as an obsession, we want to get rid of it. Get rid of that behavior. We need to develop trust with this child, with this family, right? Help them overcome their fears and understand this need to control their little environment that they're living in. We need to address the emotional memory of the child and create positive memories. And we need to help them understand social relationships and cope with the stress of they don't understand this social thing. We need to develop empathy and learn how the child comprehends the world they're living in and experiences that world. Not to say you need to do it the way I do it, or you need to understand it the way I understand it. We have to get to understand them, their world, how they're experiencing it. We need to see them as human, not an autistic person with a set of characteristics. We need to develop sensitivity to the child's needs and don't over-control, but give them some control and a sense of independence and self-determination. We definitely need humor, okay? Don't emphasize the negative, overemphasize the negative, but maintain a sense of humor, a sense of lightness. See where they're going before you tell them to stop. Be curious about their curiosity. Establish trust. Listen to what their needs and desires are. Be flexible. We all heard about being flexible. Have all kinds of plans, teachers. The A plan, the B plan, and the C plan. Because all kiddos don't learn the same way, and we just heard about that. They're all different on the spectrum. We need to help parents see capabilities, not just the disability. In seeing opportunities and embracing hope. In knowing that parents aren't alone. I mean, look at this room. It's filled with people who care and want to help support and inspire. Tosh is very limited in his communication skills and needs consistent supervision day in and day out, but he plays a mean drum, and he just learned how to play a piano. Alex, he's always been in a special day class, both public and non-public school. He has also spent time in a group home far away from his family because of his behaviors. But he's an author, and he's on his second publication of a haiku book, which you can buy at Autism Awesomeness, April 27th, free event. This is Julia. Julie's been in a special day class in public school and then also in a private special school. She reads, she writes, she loves art. She designed the logo for her classroom, and her hope is to sell some of her art too. So, how do we help these parents? We tell them they need to build the best team possible from the very beginning. They need to find a speech and language therapist who understands autism and can also connect with their child. That's key, that relationship, that connection. When a child has a way to communicate, you know that, their needs, their wants, their dislikes, and choices, there's going to be less frustration and less physical ways, right? Throwing and eloping and kicking and hitting of indicating their communication intention. They need a communication system. And remember, verbalization is only one way to communicate. There's signing, there's gesturing, there's using pictures, there's writing, and of course now there's huge technology support. But as a parent, you gotta put one in place immediately. And as a professional, we need to help them establish a communication system, not only of expressing communication, but in building receptive language. And as a speech and language therapist, I think the best way is through play. You can teach prepositions in, on, under, next to, below by creating playful sessions with them. They don't have to just sit at a table and give and touch and repetitively repeat things over and over and over again. We can teach through meaningful activities. You'd be amazed at the language that is learned through eating and dressing and brushing teeth and shopping, teaching all kinds of concepts through daily life activities. And they're meaningful activities. The next person on that team is that occupational therapist, for sure. Okay? Again, someone who connects to the child. Remember that the OT is going to be addressing sensory processing, sensory integration, motor planning, gross motor, fine motor, strength, balance, as well as focusing and shifting attention. And these are those foundational skills we just talked about and developmental milestones that they're going to help the child hit. But they also develop the foundational skills for eating and dressing and playing and taking care of all the hygiene needs. So you have to put this OT on your team. And then, what about the physical therapist? That too should be considered. And a physical therapist should evaluate the kiddo's needs and find out what kind of foundational skills for motor development and moving safely through their world this child needs. And then, of course, it's the educational specialist, that teacher who's going to determine the educational intervention to support the learning challenges of this kiddo, right? And there's so many kinds, thank goodness, of interventions available now. And again, if it's a spectrum, then one size is not going to fit them all, right? Others may respond to the program that Christine talked about, the CERTS model. Others may respond to the TEACH model, or an ABA model, or a combination of both and all. You have to know the profile of that kiddo in order to identify the intervention they truly need. And they may need one or more integrated together. I love this program we're talking about, Early Start. It's the Early Start Denver model, which came from Dr. Sally Rogers out of the Mind Institute. One of the best that's out there. So there's other people that need to be on that team, if you haven't heard. Okay? There's the medical challenges that need to be addressed. So finding a good developmental pediatrician to explore the medical challenges of kiddos on the spectrum is a good member to be on that team. Perhaps a neurologist. We know that 60% of kiddos on the spectrum develop a seizure disorder. So getting a neurologist on that team may be critical There also may need to be a person who is a doctor of internal medicine because of the intestinal challenges that also come along with autism. Sleeping. If the child doesn't sleep, the parents don't sleep. So if we're going to support the wellness of a parent, we better help them find ways to help their kiddos sleep. And if you want a child coming to your program that can engage, they need to sleep. And we're lucky here. We have San Francisco, UCSF, that has a sleep clinic. We also have Stanford that has a sleep clinic. But you're going to see as a teacher or as a parent more challenging behaviors if your kiddos aren't sleeping well. I mean, think about when you don't get that night's rest. Are you great at problem solving the next day? Not so much. So the way I see it, when medical issues have been fleshed out and addressed, when communication strategies have been put in place, when sensory and motor planning issues have been addressed, and effective educational strategies with the appropriate structured environment have been put in place, and there are still challenges, then maybe it's time to consult a behavior specialist. So the other piece of supporting parents is to connect them to all the agencies that could help them, right? Right? Because they need to acquire the knowledge to understand their kiddo and their kiddo's rights. They need to connect to parent support groups. Parent support groups, to me, are the most critical. Parent to parent, oh my goodness. You know, my child's 9 and autistic, and my child's 3. How much can that parent of that 9-year-old help that parent of that 3-year-old? Woo, lots. Finding resources and services to support those strengths, challenges, and education, medical, social, and therapeutic needs. The other piece is parents need to find out how they're going to help the siblings in their family. And the extended family, how are they going to be helped to understand that they didn't end up in Italy, that they're in Holland, right? And what about the financial and the legal issues that are facing these families? So there's lots and lots of resources that we need to hook up families to. And you've heard from Golden Gate Regional Center, certainly for early intervention and throughout life. I mean, if you didn't know that the regional center can certify the kid to go to camp, now you do. You know, or get in-home support or behavior support. The regional center can do that too. Marin County Special Education Local Plan Area, we talked with Christine about the things that are offered in the public schools. Autism Society of the Bay Area is right here, and they're holding conferences, and they're holding activities, and they have a great website that has lots of resources and what's going on in legislation. The STAR Center at UCSF does diagnostic work. It also provides intervention. Autism Fun by the Bay, this is kind of a new one. They're putting all kinds of sensory-friendly activities together, concerts, hikes, or some of those. Marin Autism Collaborative, a group that started many, many, many years ago and now is really focusing on adults and what's going to happen. Where are they going to live? What kind of employment opportunities are out there? What kind of volunteer opportunities are out there? Jewish Family Services also supports kiddos on the spectrum. And then we have those amazing special needs schools like Oak Hill School, Helix School, Star Academy, Inova, and Cypress, who are non-public schools, who are able to support those children who are not able to stay in a public school environment. Their intensities are greater. They need a higher level of therapeutic intervention. They may need a smaller class size. And then there's a sibling network. Did you know that? To help the siblings. And then there's the Autism Society of America, which puts on a yearly conference and has great knowledge on their website. And Autism Speaks, they put out the most amazing toolkits for families. If you have a dental problem, there's a toolkit for the dental problem. If you want to know how to work with the school system, there's a school system toolkit. If you want to do work on the community, there's a community toolkit. There's a vocational toolkit. There are, I think, 30 or 40 toolkits that you can send families to get resources and knowledge. And then there's the Stanford Autism Center, and there's the Kaiser Autism Center. We're pretty lucky where we live. What about grandparents? I heard there were grandparents in the room. Did you know that there was a grandparents organization? Did you know that there were books out on autism and grandparenting? There are. Just Google autism grandparenting on Amazon. What about siblings? Did you know there were books written for siblings and how to help siblings honor and respect and gain knowledge about their brother or sister on the spectrum? Adult resources. Some of those are Lifehouse Agency, Autistry Studios, Cedars of Marin, the Arc of Marin, all having their own particular programs and all servicing a different profile of autism. So it's not that all of these adult programs serve all kinds of adults on the spectrum, but they're right here in our backyard. United Cerebral Palsy of the North Bay has programs for adults on the spectrum, moving forward towards independence and becoming independent, additional adult programs. If a young person on the spectrum is capable of accessing college, there's the college internship program and the college living experience program. And they're not only in California, but they're in other states, so that if a kiddo wants to go out of state to school, they can and get a post-secondary. The technology center got started. Matrix Parent, we've talked about today, support for families, parents helping parents. Again, great connections, parent to parent. So working together is a must to get the child with autism ready for adult life, right? I mean, we can't do it alone. We all need each other. And this means preparation in school and in the home with teachers and therapists and parents. This is key. Parents nurturing independence. How? By building receptive and expressive communication skills, by addressing the sensory processing and regulation and motor planning, by addressing emotional regulation, and by developing social understanding. Those are the key areas to have a successful adult life. So, nurturing independence is everybody's job. Teaching problem solving and addressing executive functioning in these kiddos. Developing curiosity so that you can identify interests. Expanding cognition. Everybody can learn. Everybody on the spectrum has the ability to expand their cognition. Expecting them to participate in the home, making their bed, making and packing their lunches, making snacks and other meals, doing the laundry, shopping, meal planning, hygiene, setting the table, on and on and on, prepares them for life. But all of you parents who are saying, well, they need academics, all of these increase academic skills as well, and motor planning skills as well, and expand language comprehension as well. Developing volunteer opportunities to build a work resume and explore a wide variety of employment options. That's not just the school district's job. That's us as parents. Exploring their community, and this can be tough for parents, but take them everywhere. They have to get used to new and novel and different. And every place you take them to increases their language comprehension and increases their motor planning experience. It also increases the fact that maybe there's something they're going to be curious about in one of those places that you take them to, and that could eventually lead to a career or a volunteer opportunity. Developing pre-vocational skills. That's really important. And the districts and the schools do a great deal of that. Resume writing, how to interview, how to understand customer service, because there's your social skill. If you can do customer service, you got social skills. Social skills, task completion, asking for help, clarification, and punctuality all need to be taught in your pre-vocational program. There's a plethora, how's that word? I love that word. There's a plethora of resources out there on building independence. I put these two up because I really like these. Loving Push was written by Temple Grandin, a very famous young woman on the spectrum. You've probably read some of her books, but she says, okay, parents, you gotta give that gentle push, and you gotta keep pushing. This is Developing Talents by Temple Grandin, which really talks about how do we increase the vocational skills in these kiddos. And this is Asperger on the Job before Asperger was no longer Asperger. But it's a great book because it has a template in it for the young person with higher functioning, higher intelligence to really look at their skill set and then look at the skill set of a potential job they may want and see, does it match? And if it doesn't match, what skills am I needing? It's a good book, and it's written by a young woman on the spectrum. So my last thought, together with vision, we can do so much to help support the family and those who live each day on the spectrum. Thanks.
Take a few questions. Sure. Are there questions for Karen?
I can do it.
Excuse me.
Thank you very much for a very informational lecture. Is the material that you had on the screen available on your website?
No, but if you give me your email, I will send it to you.
You will?
I will.
How nice. Okay.
All right.
I'll give it to you.
I'll get it from you.
Thank you.
Great. Okay.
Thank you. Thank you for great information. And it is wonderful to know that there is a lot of resources available for parents with an autism child. My question is there enough bilingual information available for those parents who speak only Spanish and they have a child?
Good question. If you go on Autism Speaks, everything they have is also in Spanish, their toolkits. So you'll get a lot of information there.
Great. It's good to know that.
Yeah,
Thanks.
good question.
Yeah, so on the autismspeaks.org, on the website, upper right-hand side, there's a button for Spanish. And as she said, the whole site is translated into Spanish, and then the toolkits themselves. So it would be really helpful for parents.
Mm-hmm.
Other questions? Well, thank you. Thank you, Karen. And thanks to all of our speakers today. We really appreciate it. Very informative session. And thanks to all of you for your patience. Did you have another question?
No, I did. I just wanted her to repeat. I have parent support, and then I missed it yet.
Okay, parent.
The letter U at Comcast.net. I also have a brochure out there. I also have a little handout that has a list of resources of when you first diagnose, your education years, and adult. And if it'll have on the yellow brick road on the front.
And if anyone else had any questions, my email is at the bottom of your agenda. You're welcome to send me a note, and I will track down whatever you need. Thanks again for coming.